So this is a 69-year-old who had right groin pain with weight bearing, had occasional use of an assisted device prior to basically a fall into a door side frame at a store, like a automatic door, like hit her, she hit the other side. She has multiple medical issues, as you can see. She presents to the ER, had pain secondary to her rami fractures, but really no pain posteriorly, and you can see that she's had a previous lumbosacral fusion. She then presents to clinic 3 weeks later and is having increasing pain. You can see that she's actually starting to show some callus anteriorly, and we're getting close a little bit on time, but to be respectful of your time, there's callus forming anteriorly, and she has basically a peri-implant fracture around her lumbosacral fixation. And so she's obviously trying to heal it at 3 weeks, but her pain's actually increasing. And she said, I have a 90-year-old mother, and my 90-year-old mother can get around better than I can. She's basically in a wheelchair. And so she doesn't really have any rotational deformity. It's really just the Brauman's type 2 that's really not displaced at all. We tried another month of non-operative treatment. 5 months later, she comes back, and you can see that she has basically hypertrophic delayed or non-unions of her rami fractures anteriorly. She's using a walker and a wheelchair. Right anterior pain is greater than posterior pain, and she is tender over her sacrum. So she really wants something done. She has significant risk factors for delayed or non-unions, including she's had her lumbosacral fusion, so she's got an increased rigidity posteriorly, which she's kind of more going to the insufficiency fracture mode back there for that particular fracture. She's also had a gastric bypass, so I don't know if you take care of these patients, but their risk of like a distal radius fracture within 4 years is 4 times higher than the normal population. So they have a higher risk of osteoporosis. She's also had a family history. So these are her problems that she has. And I think at least I see one of these lumbosacral kind of sacral insufficiency fractures becoming more frequently, probably like one every other month. And so I think this is a potential kind of landslide of patients as they get older and their bone gets weaker after their lumbosacral fusion in their 40s and 50s. So this is intra-op. She had to delay because she had some heart issues, so we get to it at around 6 months. This is just showing that you can redirect if you don't get it the first time. So this is the first attempt trying to get around, and I wanted to get fixation into the first sacral segment because that's where her fracture was, around her hardware. And so this is just steering around the indwelling implants. Couldn't get the reamer pass with the first pass, so did a second attempt and just changed the trajectory some, and was able to get it into the other side. Professor Rahman showed that, increasing rigidity to the opposite side, and that's what a lot of us do for high energy patients too, increases fixation and stability. And so that was the goal, rather than she actually had like a U-shaped fracture around her implants. So I wanted to go to the other side. And so this is getting the implant in across and transsacral, transiliac, and then did a retrograde ramus screw because the 9.5 was too big for her corridor. So like the rest of the cases, she was weight bearing as tolerated immediately. She did end up going to get evaluated for bone health, worked with physical therapy. And she, at 5 weeks, she had an episode related to her blood pressure, got hypotensive and fell. She didn't have any increasing pain in her pelvis. 6 weeks, she's starting to show increasing bridging callus on her delayed hypertrophic unions. She comes back still using a walker, but she didn't really have any changes in her pelvis from this new fall. And then I just saw her about a month ago. She's 12 months out. She's now back to using a walker and actually started having junctional level radiculopathy from her previous spine surgery. And so she's in the process of getting that worked out. She definitely said it's different from her previous pelvic pain and more similar to her pain that she had prior to her back surgery. So in summary, we've heard from different cases presented. Not all geriatric pelvis fractures should be treated non-operatively. And so if you do these in your practice, or I think all of us probably see these patients, you have to figure out which ones will benefit for surgery. And it's obvious when it's obvious, but the gray zone is the hard one. And so There's a bunch of research trying to get done to try to help people delineate the gray zone, because those are the patients that may kind of hang out in the sniff for 2 months and never show up until a year later, and they're totally deconditioned. Or, they show up. I have a lady that showed up 2 years later, and it is a significant quality of life problem. Fixation, and I think most of us who fix these feel like they get improved pain and improved function afterwards. And then I think particularly in these peri-implant cases, for me, maneuverability, at least for what I wanted to do in this case, made it possible.
Hey, good morning. I'm Langdon Hartsock from Charleston, South Carolina. And I'm just going to show you a couple of cases that we've done. So I have 2 cases to show you. We've used it in revision arthroplasty cases around the hip when we need some column support. So this first patient, 65 years old, she's had bilateral total hips done elsewhere. She presented in an outside institution with hip pain for about 4 months with difficulty ambulating. She actually had, this is a revision on the left, so she had revisions on both, but she'd had recurrent dislocations previously. So she's got a dislocated hip with a periprosthetic T-type acetabular fracture and a subacute sacral fracture. So we took her to the OR and revised her. So we took the acetabular component out and used a posterior plate to get the posterior column reduced, and then placed the first implant we placed was the anterior column CurvaFix, and then just like the case you just saw, started at the iliac wing and can place this incredibly long intramedullary flexible screw type device from the iliac crest all the way down through the posterior column as some additional support along with the plate, and then cemented in a new acetabular cup with some screws that go through all that stuff. And she's actually done remarkably well. She was touchdown weight bearing immediately post-op. Sent home post-op day number 2. We saw her back a few months ago, and she's ambulating with a walker. So I think the advantage here was we were able to get immediate column support to park this acetabular component on and get some stability to put a new acetabulum in there. When you sort of look back at this initial x-ray and see the displaced acetabular fracture, this periprosthetic acetabular fracture, and basically the femoral head's articulating with the raw fracture surface there and the cup's loose. And so we were able to get that reduced, get some column support, and put in a new stable cup. And she's done fine. She's actually done quite well. The second one's a little more dramatic. She was 80-year-old woman, or is an 80-year-old woman, came in after ground level fall, presented outside an institution, hypotensive with left hip pain. She has some underlying dementia. She presented with this left periprosthetic acetabular fracture with complete dislodgement and medial displacement of her acetabular component into the pelvis. And she had iliopsoas hematoma, so she was resuscitated and stabilized, and trying to figure out what to do for this. Pretty challenging. So she actually, we actually got the transplant surgeons to help us, and that's what we found at our institution. The transplant surgeons are actually much more comfortable operating in the retroperitoneum than the general surgeons. And so she had a pararectus approach, and we were able to retrieve that displaced acetabular component. Was up underneath the vessels, and so he got that out for us. And then we went back, took the femoral head off the component, placed the anterior column screw, and this guide wire that's used for this device, I think it's just, I don't know what it is, but it's incredible. We were able to pass it across this huge gap and into the pubic ramus and the pubic parasymphyseal area. Put a CurvaFix screw down that, and then actually went intrapelvic on the pelvic brim and placed the posterior column screw. So that gave us our column support across what was a segmental defect of the acetabulum, and then cemented in a acetabular component. And she initially did well. She actually dislodged her acetabular component, had to have another surgery a few months later to put in a new acetabular component with some screws, which I think if I had to do it over again, that's what I would have done the first time, is instead of putting in a metal cemented type cup, is put in a standard cup that has lots of holes that you can just drill the screws right into the cement. And she's actually supposed to come see me in a couple of weeks, but she's been doing well. She's at a assisted living facility a few hundred miles from us, but she's doing fine. So I think the advantage, again, is that you get immediate column support. You can immediately weight bear these patients. You can get a stable acetabulum to put a new acetabular component in. It's been very gratifying to do. Thank you very much.